Hello friends, today I am going to discuss drugs used in shock. It is a very important topic in pharmacology and also in clinical medicine. So what is the definition of shock? It is a clinical state of circulatory failure characterized by hypoxia of cells. And why there is hypoxia? Due to inadequate tissue perfusion. What are the types of shock? There are mainly five types of shock: hypovolemic shock, cardiogenic, septic, anaphylactic, and neurogenic. The septic, anaphylactic, and neurogenic also called as distributive shock. Other shock are also present like endocrine shock, like obstructive shock, but these are not common. Common ones are these five. Then what are the clinical picture? Patient present with these clinical pictures like pallor, sweating, cold extremities. But some shocks there is warm activities like septic, anaphylactic, and neurogenic. Because in this there is a vasodilation. Rapid pulse, there is tachycardia and pulse is steady. Cyanosis, oliguria, mental confusion, and there is acidosis. Why there is acidosis? Because uh, anaerobic cycle can occur in this, and in anaerobic cycle you can know that there is formation of lactic acidosis. Then number one is hypovolemic shock. As the name suggests, there is hypovolemia, major reduction in blood volume. So what are the conditions? What are the causes? Most common cause is hemorrhage due to acute blood loss due to trauma, surgery, ops emergency, then in burns, loss of plasma, and in diarrhea, vomiting, there is loss of fluid and electrolyte. So these all can lead to hypovolemia and ultimately can lead to shock. And what are the pathophysiology of shock? Hypovolemic shock. If there is hypovolemia, decreased venous return, see in the picture, decrease in preload, and you all know that there is cardiac output is equal to stroke volume into heart rate. It preload is decreases, cardiac output is decreases. If cardiac output is decreases, then there is hypotension because pp is equal to cardiac output into total peripheral resistance, and it ultimately lead to tissue hypoxia, and then it lead to organ dysfunction, and it can lead to multi-organ failure, and death can occur in hypovolemic shock. It's most common shock, hypovolemic shock, and most risky also. Mortality rates are high. And what are the treatment? Number one, or most important treatment is fluid replacement. If there is loss of blood, like in hemorrhage, you can transfuse whole blood or packed RBC. If there is a burns, loss of plasma in burns, then you can give plasma, direct plasma or plasma expanders. If there is a gastric fluid is lost, then you can give Ringer's lactate. So as the component is lost, replace that one. Simple. Then what are crystalloid and colloid? Crystalloid are first line of treatment in hypovolemic shock, like normal saline 0.9%, Ringer's lactate, Hartmann solution. Colloid are plasma expanders. These are mostly used in burns, hypovolemic, and septic shock, but it is not the first line. First line is crystalloid. Then, if improvement not occur, then you can use these colloids. Then, if again there is no improvement after giving these crystalloid or colloids, then you can give inotropic agents. Inotropic agents like dopamine, or you can give alpha blockers. Uh, you can give sodium bicarbonate to correct lactic acidosis. But vasopressor agents like norepinephrine not recommended because there is already the vasoconstriction. And if you give vasopressor, then but in cases of hypotension, you can give vasopressor. The next is cardiogenic shock. In this, volume is adequate, but there is an inadequate cardiac output that can lead to hypoxia and ultimately shock. What are the causes? Most common MI, others are cardiomyopathy, arrhythmias, and valvular dysfunction. What are the pathophysiology? If there is acute MI, it can lead to ischemia, can lead to myocardial infarction, then it ultimately by three mechanisms it can lead to cardiogenic shock by decreasing the stroke volume and ultimately cardiac output and hypotension, or by increasing the left ventricular and diastolic pressure, causes pulmonary edema and hypoxia, or leads to shock by releasing the inflammatory biomarkers and catecholamines. Then what are the treatment? First, treat the cause. If there is MI, you can revascularize the blood vessels, and if and simultaneously you can give the dobutamine, because dobutamine is a beta agonist, increases the contractility, decreases the afterload, and is good for the patient having low cardiac output. Alternative, you can give the dopamine, or norepinephrine is used only in refractory cases, but in some recent books. Now there's the first line was suppressor according to the meta-analysis. Next is what are the dose specific action of dopamine. So in lower dose it acts mostly on the dopaminergic receptor, causing increase in glomerular filtration. In between doses it acts on the beta 1 receptor, increase the heart rate and cardiac contractility. And in higher doses it can act on the alpha receptors and it can cause vasoconstriction. So mostly we in cardiogenic shock we give in the lower or medium dose, not in the higher dose. Then next is septic shock. It can be resulting from the sepsis. What is sepsis? Sepsis is a life-threatening condition caused by body's response to infection that can lead to organ dysfunction and death, mostly by gram-negative bacteria. And bacteria causes a release of endotoxin. It causes vasodilation. So septic shock is a warm shock, not the cold one. So extremity is warm. Then most common organism, if there is a gram positive, then staph and aureus and streptopneumonia. But mostly, in most cases, there is a gram negative organism which is responsible for septic shock. So E. coli, Klebsiella, Pseudomonas aeruginosa are the most common. Then what is the pathophysiology? Organism is bacteria. It causes systemic inflammation. Then it leads to diffuse endothelial disruption, and it leads to hypoxia, organ dysfunction, leads to severe sepsis and multiple organ dysfunction and refractory hypertension. Then it leads to ultimately septic shock. Treatment, because there is a fluid loss comparatively, like in fluid can move from intravascular compartment to extravascular compartment, so fluid replacement is choice. But most important is empirical antibiotic therapy, mostly against the gram negative bacteria like piperacillin tazobactam, meropenem, or ticaracillin with clavulanic acid. uh, 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 Start antibiotic therapy as early as possible. Don't wait for the culture. Then you can shift from the specific after getting the culture reports. Then if you are not getting results, not improvement, then you can use vasopressors. Mostly noradrenaline is the initial vasopressor. Then vasopressin is also a vasopressor as an adjunctive treatment with noradrenaline. In refractory cases, you can use angiotensin 2, and mm, corticosteroids have some roles in refractory cases also. Then, what is vasopressin? This is hormone released from posterior pituitary. Posterior pituitary releases vasopressin and act on V1 and V2 receptors. In V1 receptor, it causes vasoconstriction. You can see in this picture, and vasoconstriction causes increased in systemic vascular resistance. Then it increases the PP ultimately, and we want that we have to increase the PP. Vasopressor causes increase in PP, and if act on the V2 receptor in kidney, it increases resorption of water. And if there is water resorption, more circulating volume, and more circulating volume, then more BP. Next is anaphylactic shock. Due to severe immediate hypersensitivity reaction, mostly type 1, it is also it causes vasodilation. If there is vasodilation, increased capillary permeability, exudation of fluid, angiolytic edema can occur, and it also lead to bronchoconstriction. Mostly by insect bite or some drugs like penicillin cause anaphylactic shock. Drug of choice is adrenaline, given by IM or subcutaneous, 1 is to 1000. But in life threatening, you may use in 1 is to 1 10,000 or 1 lakh, only in IV cases, in life threatening cases. Then adjunctive treatment is corticosteroid like hydrocort and H1 antihistaminics, because this is allergic type of reaction. You can use chlorpheniramine in IM or slow IV. Then next is neurogenic shock. It is caused by when there is spinal cord injury due to trauma, or when we give spinal epidural anesthesia, it is occur as an adverse event. Loss of tone, sympathetic tone, and there is loss of sympathetic reflex, parasympathetic, lead to hypotension, bradycardia, vasodilation. Treatment, just like hypovolemic, replace the fluid because trauma, spinal cord. Then vasopressor like noradrenaline, other sympathomimetic agents like methoxamine, mephenteramine, phenylephrine can be given in neurogenic shock. What are the key principle? Recognize shock early, assess type of shock, simultaneously initiate therapy initially, and simultaneously evaluate the cause, involve all team, aim of therapy is oxygen delivery, and identify etiology so that you can give the specific treatment, specific treat the specific cause of shock. Then what are when we start the vasoactive therapy? Vasoactive means vasopressor aneurotropy. So if there is a hypotension, okay, with high cardiac output, okay, after adequate resuscitation of volume, then vasopressor. ठीक है, hypotension हो रहा है, then vasopressor support. If there is a low cardiac output with high filling pressure, then inotropic support. Clear? Then there is some MCQ. You can try to solve this on your own, and if you want the answers, then comment me on the comment section. Number one is which fluid is typically recommended for initial resuscitation in hypovolemic shock? From the option, you can try to mark the answer. Next is what is the primary goal in the management of septic shock? Next, which of the following not a symptom of hypovolemic shock? Next, what is the first line treatment for anaphylactic shock? Next, which of the following lab values might indicate the presence of shock? Next is what is the role of corticosteroids in the management of septic shock? Thank you. I hope you understand. Thank you.